Welcome everyone to our fifth and last session of exploring best practices related to the ABCS of heart health. And today we're going to be talking about cardiac rehab and also the next steps for this collaborative. And I am Jerry Henniger. So just kind of want to go through a few housekeeping items, the same ones you've probably heard on the last 4 calls, but just as a reminder, if everyone can update the name that is in your Hollywood Square to include both your name and your organization if possible. This kind of helps us with tracking, and it also helps everyone on the call to know who is on the call with them today and for networking purposes. Then also for introductions, if you could please in chat, put your name, your title, your clinic or organization, and then your location where you're at. If you have more than one person on the call with you today on your phone line, then please add all the names in chat so we know who's all with us today. And then if you could answer the following question in chat, that would be helpful too. What is one thing from any of the previous sessions that you've been on that you have been able to put into practice or that you're trying to put into practice? So we talked about, implementing an SMBP program. We talked about aspirin use and cholesterol control. And then last month we talked about tobacco cessation. So those were the topics we've covered. So anything that you've been trying to put in place for any of those sessions, we'd love to hear about. So while you're doing that too, just a reminder that all of the sessions have been recorded. Excuse me. And so we hope that you were able to attend all the sessions live, but if you didn't, just know the recordings are there, and we've been sending those links to the recordings in our reminder emails each month. And then there will be a follow-up email from after this session that will have the recording link in it also. Just a reminder too to please mute yourself, but if you're not speaking or asking a question, we do want these sessions to be interactive though. So if you have a question anytime, please feel free to just take yourself off mute and ask the question, or also you can put it in chat. Also, if you have any comments too, the same thing, you can comment during the session or put it in chat. And lastly, we just love to see your smiling faces. So please turn on your cameras if you can. So with that, we're going to get kind of started here. First, just going to go through the objectives for our session today. And first, we're just kind of going to put that groundwork of understanding cardiac rehabilitation or cardiac rehab, what it is. We're going to identify those patients who are eligible for cardiac rehabilitation, and then talk about the value cardiac rehab holds in secondary prevention of cardiovascular disease. And then we're going to go through the next steps of the ABCS collaborative. So what we'll be doing this summer in the months to follow. So we're going to get started here with a polling question. I think Carrie's going to launch that for us. But the question is, how often does your facility make referrals to cardiac rehab? The choices are never, some of the time, most of the time, or always.
Okay, Jerry, I lost my polling question option.
Well, I mean, if it's not working too, people can just put the answers in chat too. If the polling questions are.
I apologize. It does not look like I even, oh wait, hold on a second. Let's try this again. It would help if I was looking at the right section. There it is.
Now, so yeah, so again, how often do you make referrals? Never, some of the time, most of the time, or always. So I'll give you just a few, another minute here for people to answer.
We have comments in chat as well, Jerry.
Oh, okay. Oh,
we have a sometimes and never from chat as well.
Okay, so it looks like for the majority of people, it's, well, good. Hopefully we're going to do this session today, and you guys are going to be doing it always after today. Okay, and then Carrie, if you want to pull up the next polling question, or here, I'll get rid of this one, probably would help. So the next polling question is, and this might make a difference of why you aren't making cardiac rehab referrals. How easy is it for your facility to make cardiac rehab referrals? Is it very easy, somewhat easy, a little difficult, or very difficult? It looks like we have a combination of both. Kind of, it's easy to make them, or it's kind of difficult to make them. So, okay. Well, thank you, everybody. So hopefully by the time we're done today, you're going to be able to make more cardiac rehab referrals, and we'll give you some hints on maybe ways that can make it easier to make those cardiac rehab referrals. So let's get started just with some basic information of what cardiac rehab is. For some of you, this information may be new. For some of you, this may be pretty basic information and you already know it. We just kind of want to get everybody on the same, level here when we're talking about cardiac rehab. So hopefully you'll garner some new information as we go through the session today. Cardiac rehab it's a comprehensive interdisciplinary team-based treatment approach. And it really aims to reduce the risk of death related to cardiac causes. It can help control cardiac symptoms. Also, it stabilizes or reverses atherosclerosis. We also see through cardiac rehab that it enhances not only physical functioning for those individuals who participate, but also it helps improve and enhance the individual's psychosocial and vocational status. So it does a lot of things, and it's a very, I think as we probably know, it's underutilized, but really can be very beneficial to those patients with cardiac diagnoses. So I want to talk a little bit more then about the importance of cardiac rehabilitation. Cardiovascular disease is one of the leading causes of death worldwide and is the leading cause of death in the United States. So through cardiac rehab programs, what we're aiming to do is limit the psychological and physiological stresses that are associated with cardiovascular disease. So it's not only cardiovascular disease itself, but everything that goes along with it, the management of it. So through cardiac rehab, we can limit some of those stressors. It also reduces the risk of associated mortality and improves the cardiovascular function to help patients optimize their quality of life. So that, again, that's taking some of those psychological stressors off them too, that they're feeling that they can do more and participate in life more. And then also it's there to decrease hospital readmissions. So currently the goal of the Million Hearts Initiative is to improve or have participation in cardiac rehab up to 70%. What we do know is that for individuals who complete a full program of 36 sessions of cardiac rehab, they have a 25% lower death risk. So that's where you're seeing we're, decreasing that death risk. And then also a 30% lower risk of heart attack than those who maybe only did one session. So it's not only about getting them into cardiac rehab, but getting them to continue to do the full, all the sessions. And then again, it also, by reducing hospital admissions, it saves thousands of dollars per patient of year of life saved. So there's a lot of things for your facilities to look at as to why to do cardiac rehab referrals. So talking and just kind of exploring a little bit more of those cardiac rehab benefits, as we said, it reduces the death rate. So cardiac rehab participation, it reduces all-cause mortality by 13% and death from cardiac causes by 26%. And then we talked a little bit about the hospitalizations. Again, to give you a number, but hospitalization rates, it decreases that by 31%. So also cardiac rehab has been shown to improve medication adherence. So that helps across the board too, as well as again, we'll talk about it's that functional status, patient's mood, and their quality of life. So who is all eligible to participate in cardiac rehab? Which of your patients are? And it's lots of your patients are eligible to participate in cardiac rehab. It includes those who have had a heart attack, patients who have received a stent, anyone who's undergone bypass surgery or a transplant surgery, Patients who have stable heart failure or patients who have stable angina. So quite a few patients are eligible to participate in cardiac rehab. The cardiac rehab team often includes many members that are part of your healthcare team. So it would be your cardiologist. They often include the exercise physiologist, of course, a registered nurse, a physical therapist, a dietitian, social worker, and in some cases too, a psychologist. So talking about the cardiac rehab sessions, they typically take place over an extended period of time. Usually we're looking at 3 months and include up to 36 1-hour sessions. Also, these sessions are structured, they could be structured differently in different facilities or different organizations, but they typically include like supervised exercise, of course, nutrition and lifestyle education, and then patient counseling around topics such as stress management. So again, the sessions are team-based, they're supervised, and they were looking to provide that education and skills development for heart healthy living, and then also for reducing stress and other psychological or physical psychosocial factors. So when we talk about cardiac rehab, really there's most places you look at it in 4 different phases of the cardiac rehab. As we said, the sessions are going to include like medical evaluations to start. There's going to be exercise prescribed, and then we're going to look at how we can modify those risk factors and provide education to the patients. Cardiac rehab programs, they can be conducted in hospital settings, outpatient settings, or freestanding clinics. And each phase of cardiac rehab, we're going to go through 4 of them, kind of builds upon the previous phase. So the initial phase or the acute phase of cardiac rehab occurs soon after the patient experiences their cardiac events. So those different events that we just listed for the patients that were eligible. Often this phase may start as soon as the patient while they're still in the hospital setting. So maybe when it's still in their ICU or they're in a step-down unit. The initial goals of this first phase of cardiac rehab, they include assessing the mobility and the effects that basic functional mobility has on the cardiovascular system. So going through that with the patient. You want to work with healthcare providers, nurses, and other therapists. You want to ensure that they have the appropriate discharge planning has started, because again, we're looking often at when that patient is still in the acute care setting. We're looking at prescribing safe exercises to help improve mobility. We've done that mobility assessment. So then how can we improve on their mobility and also improve their cardiac fitness? We're going to address the risk factors that may lead to the cardiac events with the patient, prescribe appropriate assistive devices. So again, maybe a patient needs a cane or a walker that they didn't need before they had this event. Because we want to make sure that the patient feels safe, because if they don't feel safe walking or doing the exercises that we're going to prescribe for them, then they're not going to do them. So if there is any assisted device that they need, we want to make sure those are available and given to the patient. And then you're not only working with the patient, but the family. You want to make sure that you're providing them education about their cardiac condition, and what the expected benefits are of the cardiac rehab program, any associated risks, and just those things that what the outcome is going to, what outcome that they want as a patient, but kind of what you are expecting for them. Once significant healing has taken place, the patient may be discharged to home, and they would begin phase 2 of their cardiac rehabilitation. This is the subacute phase or the second phase, and then so this continues usually in an outpatient facility, or it could be like in a clinic setting too. It depends upon where the patient is discharged to. If they're discharged in the home, they might go to an outpatient clinic, whereas there may be gone to a step down unit or a rehab center. So phase 2 of cardiac rehab usually lasts from 3 to 6 weeks, and it involves the continued monitoring of the patient's cardiac responses to the exercises and the activities that you've put in place for them. Another important aspect of phase 2 of cardiac rehabilitation is the education that needs to be provided. And this is about the proper exercise procedures and about how to self-monitor heart rate and exertion levels during exercise, because we're preparing the patient to be able to do this on their own after they're discharged, from the cardiac rehab program. So they need to know, that they're doing the exercises appropriately and then monitoring their own status. So you're looking at their, can they monitor their heart rate? Do they know what they need to do if their heart rate is too fast? Those types of things. And towards the end of phase 2, the patient should be ready to be more independent with their exercises and with their activity. So phase 3 of cardiac rehab involves, this is when, as we said, that they're more independent, and it might be in a group exercise setting. Here they really are focusing on the rate of perceived exertion. The physical therapist is again present during this phase to help the patient increase their exercise tolerance and monitor any negative changes that may occur during this phase of the rehab. So we're really, again, building them up to be independent where they're going to be doing this on their own. So then the final phase of cardiac rehabilitation is the patient's own independent and ongoing conditioning. So here the patient, they've participated fully in their previous 3 phases. They should have an excellent knowledge of all about their condition, because again, we've been teaching them not only the exercises, but about their condition, any risk factors that they should avoid, and any strategies to maintain optimal health. So we're not only having them exercise in cardiac rehab, but there is education that also needs to be done. You want to make sure that they know and are independent in their exercise and conditioning program, so that they can maintain their optimal health and prevent any possible future cardiac events. And while this is kind of like an independent or maintenance phase, the patient needs to know that the rehabilitation team is still there for them if they have questions that they can ask. And, they may need to come back in and get a refresher if they have some questions, or if things just aren't progressing the way that they feel they should be at home. Also, I just wanted to let you know, and we saw this a lot during COVID-19, there were programs that were set up virtually for cardiac rehab. So if patients aren't able to come in to a facility for cardiac rehab, they can do some virtual cardiac rehab sessions. But and then from there, if that's how they need to start, or maybe it's like one time a week they do virtual, and one time a week they come in. So it's just to know that those are things that can be set up too. So we talked a little bit about what cardiac rehab is and why it's important. I wanted to touch a little bit on not only the benefits, but, even though we have this great, we have cardiac rehab, and we know how wonderful it can be for patients, participation rates still remain pretty low. In January 2020, there was an article published in the American Heart Association journals. It's called Tracking Cardiac Rehabilitation Participation and Completion Among Medicare Beneficiaries to Inform the Efforts of a National Initiative. Long name. And it's linked here at the bottom of this slide. But anyway, what this article showed was that cardiac rehab really is not, we have like a 24%, only 1 in 4, it's actually 24.4% of Medicare beneficiaries participated in cardiac rehab. So we have a lot of work to do. And part of what the article looked at is, they wanted to standardize the way to see, why weren't people participating? Did they not know about eligibility? Were there not programs? What were the issues? So they kind of broke it down into, different areas, looking at the different disparities that existed. And we'll talk a little bit more about those too. So, but really there's disparities by sex, by race and ethnicity, by qualifying conditions, and then also by geography. So we'll talk a little bit more about these on these next slides. What we do know from that study, when we broke down the data, even though we know cardiac rehab is important, the patients with qualifying cardiac events, the Medicare patients aren't participating, patients with insurance aren't participating. So if we break it down, the oldest adults, so those who are 85 and older, are 48% less likely to participate than adults who are 65 to 74-year-old. So we're seeing that as patients get older, they don't participate. So adults who are 45 to 64% are 15% more likely to participate than those who are 65 to 74. So just like I said, as the patients get older, they're less likely to participate. Women are 10% less likely to participate than men in cardiac rehab. Non-Hispanic whites had the highest participation rate. Hispanics came in next at 13.2%, and then non-Hispanic blacks came in at 13.6%. Sorry, flip that around. Non-Hispanic blacks was ahead of the non-Hispanic whites as far as who participated. And then really we saw that the rates of participation were considerably lower for those beneficiaries or patients who had more than 5 comorbidities compared to those who maybe had no comorbidities or only less than 2. So basically, the sicker the patient is, the less likely they were to participate in cardiac rehab. But looking at that too, only 3.2% of patients who had a secondary qualifying condition participated in cardiac rehab. Commercial and Medicaid beneficiaries were actually 50% and 18% respectively more likely than those dual eligible beneficiaries to participate. And then patients, just as an FYI, patients who have had a CABG were the most likely to participate. So 70.2%, while patients who had acute MIs but had no procedures were the least likely to present at 16.8%. So that's kind of what that article shows. It just really breaks down at, if you really want to look at who is and isn't participating. So looking at, again, at we know there's barriers to participation in cardiac rehab. So we're going to look a little bit at these contributing factors. Are many. They occur at the health system level, policy, program, patient levels. There's a lot of different things to deal with and to find out why patients might not be participating. To start with, there's socioeconomic barriers. And so there's things like the cost. So, it isn't covered 100% in most cases. So what is that, percentage that even if it's covered at 80%, there's 20% that the patient has to pay. So that can be a factor. Transportation can be a factor. There's a time commitment, as we said, 36 sessions, 1-hour sessions. And so it's not only the time commitment for the patient, but if they have to have somebody who brings them there, which is probably going to be the case, especially in those acute and subacute phases 1 and 2. So there's that whole time element. There's, as I said, the caregiver responsibilities, they have to go with them. For those patients who are maybe still employed, especially as you get into those latter phases of completing the program, maybe they've gone back to work, they were still working, those younger beneficiaries. And as I said, transportation, so that travel that they have to do. We also know that people who make more than $75,000 per year are twice as likely to participate than individuals who have an annual income below $15,000. So that's that kind of plays into it too. Also, people who live outside metropolitan areas are 30% less likely to participate in cardiac rehab programs. Again, that whole transportation, and also not only the transportation, but is there even a cardiac rehab program near them? Next, there's the psychological factors. These, again, as we talked about, can be considerable. There's a lot of evidence that the heart and mind go hand in hand when people are healing. So we need to not only treat, and that's what cardiac rehab is there for. It's not only treating that physical part that was broken of heart disease, but it also looks at the psychological issues and the stresses that are part of that and addresses those barriers. So again, looking at lifestyle changes, tobacco cessation, also patients with heart disease, and they also often have depression that goes with that. And this costs the society 33% more than those patients who don't have depression. So, that goes along a lot of times when a person has had a cardiovascular event. So cardiac rehab is there to kind of help identify that and help those patients get treatment. Then also cardiac rehabilitation programs, they aim to limit both the physiological and psychological stresses that go along with that. So we've talked a little bit about identifying the depression, but those factors really lead into mortality a lot of times if they're not addressed. So by identifying them as part of a by having the patient in a cardiac rehab program and getting the patient treatment, it really can be helpful for the patients in not only looking at healthcare costs, but also in decreasing mortality. Physical barriers that can be part of not participating in cardiac rehab. Let's face it, they've got cardiovascular disease, or they've maybe had a cardiac surgery or a major cardiovascular event. They're going to be fatigued. They've got shortness of breath. They maybe aren't able to walk like they did before. They might need an aid. They aren't able to do their ADLs like they were before. So these can be a big part of not participating, why patients don't want to participate in cardiac rehab, which part of by participating, we can let the patients know we can help them get back to as close to where they were prior to the event. And then the motivation too is a critical factor too for this, because the longer a patient has to wait to start cardiac rehab, that's why it's so important if we can get it started even while they're in the hospital. If they have to wait to get into a cardiac rehab program, then the likelihood that they're not going to participate, it increases actually by 1% by every day that they aren't in the program. So if say they're discharged from the hospital, but they can't even start phase 1 until 2 weeks later, that's, already we're at 14% less likely to participate. So to get them up and going as soon as possible is really important. And so for the cardiac rehab programs, I think it's really important too to look at those motivational factors for the patients. What are the patient's beliefs? What do they want to get out of cardiac rehab? I think as practitioners, we always have, what our goal is, is we want the patients to get better. But we also have to look at what is the patient's goal for this, and really support what they want to get out of cardiac rehab so that, again, we can get them, back to their best quality of life. Here's a nice table that really looks at how we can reduce the barriers of participation in cardiac rehab. So to look at some of the different strategies, first, I think the first, and maybe, I don't know if it's the easiest, but one that really works well is having that, to use the opt-out process. So you can have it that your EHR automatically generates a referral. So to not do a cardiac rehab referral, the patient or the physician would actually have to uncheck the box. So it's just kind of an automatic that, if they have one of those qualifying diagnoses, that a referral automatically happens. The greatest predictor actually of a patient participating in cardiac rehab is their physician's recommendations. So patients listen to their doctors. So we want to make sure that providers are talking to the doctors about their expectations for cardiac rehab. In fact, we know a facility where the provider expects any patient who has a qualifying event that they're going to participate in cardiac rehab. So, letting patients know that this is the expectation. Just like if you're going to take your medication, you need to, that's an expectation that we hope patients are doing, but that the expectation is also that they're going to participate in cardiac rehab. Also, part of the enrollment process improvement work should really focus on patients who maybe were referred, we had that automatic referral, they were set up for cardiac rehab, but they didn't show up. And so putting a process in place for why the patients, or for patients who don't show up. And so you might want to just start with, as an example, that you call the patient, 3 times when they don't call up, and then follow that up with a letter if they don't show up, or if you have an email, that you can email them or use my chart, however you're going to message the patient. Also, you should make sure that the patient or the patient's physician is aware that they're not showing up for cardiac rehab. So that's also an important part of it. Just, not only the patients who are there, but the patients who aren't showing up. As I said earlier, to make sure we're reducing that interval between hospital discharge and the start of the cardiac rehab. So again, making sure that everything, if it's not taking place within the hospital walls before their discharge, that it's set up so that they know, okay, I go home on Tuesday and I'm going to cardiac rehab on Wednesday, so that they have that date and they have all the information to go there. Also, using like your community health workers, or your home health agencies and home health aides, or even visiting nurses to, they can be an extension of your facilities to help get patients into cardiac rehab. It's important too that you're designing a culturally and linguistically, appropriate programs. So having translation services available. Also, having diversity amongst your cardiac rehab teams. Research has shown that minority physicians are more likely than white physicians to care for minority or low income or uninsured and underserved people. So making sure that your team is diverse is an important part to reducing some of those barriers. You also want to make sure you're ensuring access to services, like if the transportation is an issue, hopefully, is there a transportation service you can set them up with, or just some way that you are at least aware, asking patients, again, if they're a no-show or before they're discharged even, what transportation is going to look like for them. Working with some of the different payers to maybe reduce some of that financial burden. Like I said, if there's a copay, that might be what's keeping the patient from it. So if there's any way you can work with your their payers, that's another way to reduce the burden. And then also just make sure you have a process in place to talk to your patients, especially those patients who drop out of cardiac rehab, why they dropped out, because that is what you can look to help improve your programs. So here we're kind of looking at, again, we talked about barriers, maybe these are some things that we've heard back from some different cardiac rehab providers, some lessons learned. So really, like I said before, it starts with the provider. The provider needs to make that recommendation to their patient. The patients are going to listen to them. The family of the patient's going to listen to them. So they need to make that recommendation, and that's where we're going to see better participation. Also, it's important to get primary care providers involved in heart failure or unstable angina patients. Maybe they were hospitalized and their PCP didn't know about it, and they didn't get referred. So making sure that they're part of that process of getting patients referred. Also, for oftentimes treatment plans maybe don't get signed by the referring provider. So we want to make sure that there's a process in place that happens, that maybe it automatically goes to the medical director. This can alleviate problems, if treatment plans aren't getting signed off on, things aren't getting done. And then also just following up with patients as needed when they're doing their cardiac rehab. What are their concerns? How can you help fix those concerns? Those kind of things. Another kind of a lesson learned too, but you want to capture the patient experience again to help alleviate barriers and to improve your programs. So make sure you find ways to include patient feedback. So, and you probably want to put a more formal process, because you're probably going to hear your physical therapist or, you know, the provider who's working with the patient during physical or during the rehab. They might make comments to them. So make sure you have some type of formal practice or informal practice to capture this feedback. You know, I know we can always give forms to the patients, but just even if a patient is talking to their therapist, that there's a way that the therapist can maybe capture it and write it down, because those are sometimes probably the most valuable that we hear. And so that's why we want to also maybe incorporate like a patient advisory group. I'm sure you all have those at your facility, but that's another way of capturing feedback. And you want to capture it from their experience and the perspective of, you know, who received a referral and did enroll. So you know, these first couple bullet points, we're talking about getting that feedback from the patients who actually participate, right? But what about those patients who never enrolled? Why didn't they enroll? Or the patients are enrolled, but they never completed the program. And also you want to get feedback from those who completed the program, of course, too. But sometimes you get the most valuable feedback from those who don't complete the program or never even started. And then it's important to share patient stories with your staff and the providers and even the prospective patients. We actually you'll see this a couple slides in the future, we actually have a patient story that you can listen to. And it helps motivate patients to maybe hear from other patients why they went to rehab. So here's just a little bit on the slide about billing for cardiac rehab. There's actually a link at the bottom of this page to conditions of coverage for outpatient cardiac rehab. That is a great document to refer to for billing for cardiac rehab, because that can be a barrier. If you're not getting paid for it, you know, it makes a big difference. So first of all, Medicare Part B covers cardiac rehab for patients with cardiovascular disease and one or more of the qualifying events, as we noted on slide 9. Cardiac rehab should take place either in a physician's office or a hospital outpatient setting. As I said, it can take place actually in the hospital at the start. And then cardiac rehab programs, they must include the following components. They must have a physician prescribed exercise program. They have to aim at cardiac risk factor modification. So that needs to be part of that care plan when you're setting that up for the patient. Psychosocial assessment, outcomes assessment, and then individualized treatment plan. So that's all part of that, what you're putting together for the patient. And again, Medicare limits the number of sessions to a maximum of 2 60-minute sessions per day, up to 36 sessions for a period of no more than 36 weeks. So as I said, this is, we're not going to go through this today. It's about 9 minutes, a little over 9 minutes long. We don't really have time to do that, unfortunately, but it's a great patient story. The patient here talks about his experience with cardiac rehab, and it was a positive one. But, you know, just give some insights too, I think, for you to all listen to and maybe, you know, help improve your programs or some things that they saw as part of participating in cardiac rehab. So you can listen to that at your leisure. And then here are the cardiac rehab resources. I think most of these were linked at the bottom of the slides, but just wanted to put them all together on one slide for you. And now I want to go through, this is our last session of our 5 sessions of the ABCS Collaborative. So want to talk about our next steps. Sorry, I've been talking a lot. And I just want to check, this might be a good spot. Carrie or Rachel, are there any questions in chat that we should be answering?
No questions at this time, Jerry.
Okay,
No, thank you.
So here's our follow-up activities for part of this collaborative. So in the next few weeks, you're gonna have a quality improvement advisor, or a QIA, will reach out to each organization. So each organization will have a quality improvement advisor, and we're going to schedule one-to-one follow-up calls. These are going to start in July, and no, they'll just be Zoom calls or just virtual calls. And, we'll just schedule them for like a half hour long. If they only take 10 minutes, they only take 10 minutes. It's just kind of, we want to follow up on the information that we provided with you, and, how your program is going, especially putting your SMBP programs in place. So we'll get those scheduled starting in July. And then what we will go through as part of these calls too is we would like to get some data back. And hopefully this isn't too much data that we're asking for. Really, it's basically, and we'll talk about this with you on the calls, the number of staff that you trained as part of your SMBP monitoring programs, and then the number of patients you have enrolled, and then that's kind of broken down into like the current number, and then the number of patients who've maybe broken from the SMB program. So it's really this data that we're asking for is focused mostly on the SMB program that, we'll provide, we're going to be sending out blood pressure cups to you for. So putting it all together, this is just I'm gonna quickly get through this here. Just want to summarize what we've talked about over the last 5 months. So we started with the SMBP program, the self-measured blood pressure program. So just a couple of highlights here that we pulled from those 2 sessions. Those were our first 2 sessions that, there's strong evidence that shows that SMBP monitoring programs provide clinical support, help patients with hypertension lower their blood pressure. And then also can be used to diagnose suspected hypertension. It's important to identify at least one provider and one care team member to be their champions. And these providers then can be the ones who do the training. You want to make sure you have processes and workflows in place and involve a variety of staff, and make sure the staff know what their role is as part of the program. And then when you're identifying patients who are likely to benefit from an SMBP program, it's really important to make sure that the patient is engaged and to be part of that program. That's where you're going to see more success, that the patient really understands why you're asking them to do this at home and are really willing to do the work. And then make sure that you're only using blood pressure devices that have been validated for clinical accuracy, which is the blood pressure cuffs we'll be sending to you guys for participating. Aspirin use and cholesterol management was the 3rd session we did. And just a couple quick things from that. Really, the United States Preventive Services Task Force doesn't recommend any patients over 60 be given aspirin as primary prevention for atherosclerotic or oh gal, now I can't even talk anymore. ASCVD. I think y'all know what I'm talking about. Decisions should be based on clinical judgment for long-term antiplatelet strategy. Look at risk factors for elevated cholesterol. Those that the patient can control are things like physical activity, dietary choices, maintaining a healthy weight, tobacco cessation, limiting alcohol, and stress management. Excuse me. Statin medications are used to lower LDL cholesterol, and they do this by slowing liver production of and increasing removal of cholesterol from the blood. And patient education and shared decision making are important components in helping patients manage their cholesterol. Sorry about that. Tobacco cessation. Really, the biggest point here, I think, is that healthcare providers have a professional obligation to help patients improve their health, and this includes addressing tobacco use and helping patients quit tobacco. And I think it's also very important to make sure that we're honest as providers. So if a patient asks if you as a provider, if you use tobacco and you have, you should be honest about that. Make sure that you assess every patient's willingness to quit if they're going to start a tobacco cessation program. And then again, change is a process. And we have the 5 different stages listed here of pre-contemplation, contemplation, preparation, action, and maintenance. And then lastly, the cardiac rehab, which we went through today. I'm not going to go through the bullet points here since we just went through them all, but just wanted to make sure we have a summary for that there too. Are there any questions? I was going to say one thing I forgot to mention when I was talking about earlier, the follow-up, we're going to do the one-to-one calls. I believe everyone has let us know, we need to know the main contact person for each of your clinic groups, who are going to be sending the blood pressure cuffs to, and then the number you need. I'm pretty sure we have that for everybody, but if you don't think we have it, please just reach out, or you can put it in chat, or you can email it to me. My email address is jhenniker@stratushealth.org. And I think Carrie or Rachel can pop that in chat. Are there any questions? I know we covered a lot today. There aren't any questions. Actually, we can go ahead to the polling questions. And if you guys think of something, just take yourself off mute, or you can put your question in chat. The first polling question, Carrie, if you can pull it up, but I learned something useful as part of this collaborative. Basically, yes, no, or unsure. Looks like everybody that answered learned something, so that's good. Oops. And then our next polling question is, overall, how satisfied were you with the information provided as part of this collaborative? Very satisfied, satisfied partially, or not satisfied? And if you guys have any ideas too for improvement and you want to put them in chat, you can put them in chat, or again, feel free to email them to me. We're always looking at ways to improve. So we can continue the conversation on Connect. As you know, there's an area on Connect specifically for this collaborative. I want to get to the next slide here though too before we wrap up. Superior Health is offering free on-site mobile vaccination clinics and health fairs. So it's a COVID-19 vaccination clinic with health education topics that include self-measured blood pressure, which you guys are all experts at, chronic kidney disease, safe opioid use and substance use disorder and stigma, dietary resources, cancer screening, mobility resources, tobacco cessation, which we also covered in this session, and more. So if you would want a free mobile vaccination clinic or health fair in your community, we've got the links or the emails that you can go to. So either of these, you can do it via email or you can do a request form. So great opportunity. Whoever, I think please take advantage of it for your areas. And I just want to check again, make sure, are there any questions or anything, any comments that anybody has? Or any questions too about the follow-up calls or the blood pressure cuffs that people might have? I'm just drawing this out because I'm sad that this is the end. But if there aren't any questions, and again, we'll be talking with you guys in the coming months this summer too. So I just want to thank you all for participating. We've really enjoyed putting this together for all of you and having you all participate. And with that, I'm going to wrap it up. That's it. Thank you, everyone.